Good evening, everybody. Thank you very much, and good evening for everybody that's online. We'd like to welcome you tonight to a Compass MS Care program. This is Compass MS Care, Rural America, and Underserved Communities. To support tonight's program, we have Bristol-Myers Squibb, Genentech, Sandoz, and TG Therapeutics. Let's give them a round of applause, please. We couldn't do these programs without them. So I don't really want to take time from everybody else other than also thank our exhibitors. We had Alexion, Bristol-Myers Squibb, Genentech, Novartis, Sandoz, TG Therapeutics, and Viatris. I want to thank them all for being here as well. So Dr. Hughes, come on up, all right? Let's get this started and get going here. And these people want to eat, and we'll get them all going at the same time. Thank you.
So doing a program for Stuart is always a very interesting experience, more ways than one. But I think, when I've talked to other neurologists who focus on MS, we all really have a respect for the programs that he does, that he's continuing to do those programs. We may have conversations among ourselves like, how many have you done this year? I did 2. I did 1. But it really is this a great opportunity to speak to topics that I don't always get an opportunity to speak to. And we always get our marching orders. I always say that Stuart asks you to talk about zebras, and he says, throw in some fish, and if you're done, let's go ahead and talk about the way of making bread. So sometimes it's hard to make it if it feels a little bit choppy. All Stuart's talk is what they need. But he does have an ear to the ground, and it's a well-timed topic. So there wasn't anything that I said. I guess the first thing, is there anything that I could say I didn't know what to say about? I didn't have to look anything up. That's very reassuring for some of my patients in the room. He asked me, did I get that? I even wrote myself an agenda in my talk to make sure I stayed on track. So MS 101. This is a whole 5-day conference all by itself. But what I wanted to do with this was to talk about the basics, but then talk about where our understanding of MS has evolved. Because I think it's a very important background before we start to talk about new and emerging treatments for MS and looking at what are some of the potential targets. There are 2 things that make me feel old. One is the picture that he still has on my slide. Obviously, I've had some hair growth since then, and so that's a few years old. Remind me to send you a newer one, Stuart. But the other is when I talk about the basics. Because I've been doing this for a few years, and what we thought were the basics and what we thought we knew is just, some of it was wrong, and I always think of a talk that I gave probably 25 years ago now, where I was talking about what the future of treatments was going to be. And that's back when we had to make our own slides. So I had a box, and then it was like a rocket, and it was really pretty. And it's so wrong when I was trying to predict what I'd be saying today. And a lot of the reason why it's wrong is because we understand so much more about what is this disease we call MS. So I'm glad I was wrong. A bit humbled about my ability to make predictions. So don't ask me what the lottery numbers are. I have no idea. So just so I know, and I know there are people online who can't respond to this, but let me just get a sense of who's in the room, because how basic do I need to go? If you've been diagnosed less than a year, can you at least show me a finger? You don't have to let everybody know. All right. Hats off to being here. If you've been diagnosed less than 5 years, all right. And the rest of y'all could do this talk. Okay. So our basic concept of MS is that for some reason, the body made a mistake. And instead of recognizing something foreign to itself, like a bacteria or a virus, it recognizes a part of itself, and in this case, the conductive coating around the nerves called the myelin. And nerves are just like wires. Okay, actually, electricians have told me I'm wrong with this analogy, but it works. Let's just go with this as Hughes' understanding of electricity. When you talk about a wire, you got 2 parts. You got the wire, the metal part that runs through, and then you have that plastic conductive coating around it. And if I take, I always use the analogy of a toaster oven. I have no idea. Has anybody seen a toaster oven recently? But anyway, so if I take the wire to a toaster oven and I strip off that black part. My toaster oven is probably still going to work, but I might have to wiggle it, jiggle it, probably put my house at risk for fire, but I can still get that toaster oven to work. If I take a knife and cut through it, my husband would say you can still fix that, but I can't, all right? So that information, the toaster oven, is time for a new toaster oven. Now, I could take that toaster oven, if that electrical part is stripped, I could duct tape it, and I can get it working, but it's probably not as good as it was before that conductive coating around of that wire's been affected. With MS, the same thing. So when the body makes a mistake, it recognizes that conductive coating as being abnormal and it strips it off. And wherever that nerve is going to, the information is not going to travel through quite as fast. It might travel 5% slower, which means we might see it on an MRI, but you knew nothing about it. Or it might travel through 90% slower, and you know about it, and we can see it on the MRI. All right? The good news is the body is always trying to heal itself, and it may be better than duct tape. When what we're trying to do with a lot of our treatments is to get out of the way of the body's ability to repair itself. And I think that's a really exciting point when we start talking about some of these new therapeutic options that will hopefully be coming to the market soon. We always focus predominantly on the conductive coating, the myelin. We didn't spend a lot of time talking about the wires. And the reality is, if you go back in the 1800s, I don't know how they practiced medicine then, but apparently without MRIs and all the other things we had. But even then, they recognized that there was something wrong with the wires themselves, the neurons themselves, and this changing recognition of the role of the actual axon and how that is impacted in the process of MS. Also kind of impacts our treatment options and future treatments from that. Now, I had the pleasure of attending ECTRIMS, which unfortunately was held in Milan this year. I have to say that because my husband's in my room, and just hats off to my driver, my supporter. He gets me places. I think he was a little too happy when I went off to Milan. I was in no hurry for me to come back, and I won't ask any questions about that. Okay, one more slide, and then I'll talk to you, because there were a few topics, like what do you take away from a meeting, right? You got to pretend like you attended it. Other than my new shoes, I don't have new shoes. But what were some of the topics? And one was this concept of what else is going on with MS. This is kind of our classic picture. If you've had MS for more than a year and you've not seen this slide presented, then you're not doing something right, because everybody has to present that at least once. And what we're talking about is there's a range of things on here. So relapsing remitting MS. Some people should say we should just throw that away. Because in relapsing remitting, when you're in remission from cancer, you don't have cancer, right? But there is no remission from MS. You always have MS. You may not be having an acute relapse, but the disease activity itself is continuing on. And so when I first started, I'd ask a patient, hey, anything new happened? And the patient said, no, I haven't had anything. And I patted myself on my back and said, excellent neurologist, right? I didn't recognize that independent to the relapses, patients were still changing. And that's what you see with the stepwise, right? And so those are the relapses. So the patient says, I was fine, but last Tuesday, my left arm wasn't working as well. And then I guess it's gotten better over the last couple of days. It may get 100% better. It may get 50% better. It may get 10% better. As long as it got better, that met any degree of better, that met the definition of remission. And that's why a lot of patients say, I don't think I have that relapsing because I never got better. And they're absolutely correct. And we're acknowledging that with the language. MRIs. Well, early on in disease activity, there's a lot of MRI activity. And there's nothing more frustrating from both standpoints, from both the physician and the patient standpoint, to say, I don't think I'm doing so well. Well, your MRI is stable. It hadn't changed, right? And this recognition that what we can capture with the MRI is just what's above the water in an iceberg, right? There's a lot going on underneath, and it's not that patients were not correct, it's we just didn't know how to measure that and how to understand that. And those are some of the advances, because obviously we want to treat the relapses, right? But we also want to prevent that progression disability down the road. And as I got older, maybe that's why I stopped patting myself on the back, is early on, you see a relapse, it's fine. 10 years later, there's a few patients I've had longer than that. We're not going to name anybody, right? And things change, but there's no more relapses. And so we want to be both treating for the relapses, but we also want to be thinking about the future. We talk about MS being a very inflammatory disease. That's the reflection of the body responding to something abnormal. Transitioning to a neurodegenerative disease where we say, well, now there's changes in the wire. Remember, there's no good way to fix the wire. But now we realize that neurodegeneration is happening from the very beginning, that it's not an A then B, that one process may be more apparent to us, but both of them are going from the very beginning. And we need to widen our treatment options to encompass both. Bad news is all our brains are shrinking. Some of y'all have already heard me say this, and I love this fact. The good news is men's brains shrink faster. I try to say that at least twice a day, and it helps me go home at night. I know everyone turned and looked at my husband. He's heard it. He's ignored it. He's not paying any attention. But sometimes with MS, what we will see is atrophy advance for age, right? And so if our normal rate of atrophy is 1 to 2%, neurologists are full of trivia, 1 to 2%. People with MS may see atrophy rates at 4%, almost twice. That doesn't sound that exciting if you've been, in 20, I could care less. At 25, don't ask any questions, I care more, right? Because I want all I can get. So this is where we're kind of changing. There's a term called PURA. Oh, goodness gracious. When I'm on camera, I can't remember what that stands for. Progression independent of relapse activity. And so it speaks to that experience with I'm not having relapses. It speaks to that experience if my MRI is stable, but I know things are changing. And these are 3 different ways that we can pick this up. There's the standardized test mostly done in research trials because it's a little too intense to do it it's a lot too intense. It takes about 45 minutes. So if you have an exam that takes 45 minutes of your visit, well, y'all know that ain't happening. But it's a very detailed, and so what it really captures is this progression over time. A test as simple as time 25 walk. How many of y'all done a time 25 walk? We started started assessment at clinic in my practice just to try to capture that. Because the reality is it's a very simple test. We have people start, walk comfortably 25 feet, and we time that. And then we have them walk back. And that change in how long it takes people to walk is very, very correlated with people's progression. And so the question always is, well, you'd like to know what it was 2 years ago, so you know if somebody's stable or not stable. 9-hole peg test is Cracker Barrel used to have, I guess pre-COVID. I don't know if they put those little triangles out with the pegs. Is there anybody in here who hasn't played with that? Well, that is also a very sophisticated 9-hole peg test, except instead of trying to figure out how to play tic-tac-toe, yeah. You have pegs in a little bowl. You take them and you put them in each of the holes as fast as you can, and then you take them back out. Very simple assessments that we can incorporate to really try to capture that what patients are referring to when they're saying there are things that are changing, because we want to identify this as early as possible. But this term PURA, progression independent of relapse activity, we've been sort of where it happens, but what's new is kind of understanding what's happening underneath that. So then the slides get harder, and no, I don't. There's a gentleman in the back, I won't point him out, that always teases second time, and he sits as far from me as possible. I'm not exactly sure what he's trying to say. I checked his hearing just to make sure he could hear me. He assures me his hearing is just fine. He just doesn't want to be near me. See, when I get the mic, I get to tell the story the way I want to tell the story. But what we've talked about in MS is these activated lymphocytes in the periphery, in the bloodstream. But now the recognition is not only are activated lymphocytes in the bloodstream, but that they are also along the surface of the brain. And so you see these follicles, B-cell nests. And when you're in the relapsing phase, you don't have as many. But as you start to progress, the concentration, the density of these activated B cells along the surface of the brain are higher. So they're increasing over time. There's two things that's humbling about that. There's one, that they're there from the very beginning. So that's a target we haven't been addressing. And then recognizing that this is changing over time. So it gives us an opportunity to say, what potential role can this be playing in that unmet need? Okay, one of many unmet needs in treating people with MS to the best of our ability. This slide I just thought we'd just go over in 2 minutes or less. I laugh because there's a lot on this slide. But it also is very interested in talking about where we started and where we are now. And so to make it a little simple, so before we talk about the emerging, I want to talk a little bit about how our drugs that we currently have are working. So we start with the earliest generation medication, the interferons, your beta-seron, your Avonex. We talk about glatiramer acetate or your Copaxone. It has newer names now. And really what we were doing with those drugs is we said, the immune system is activated. Can we rebalance that so it's in a less active state? Next generation of drugs were the S1P modulators, your Gilenias, your Mayzents, there's always one more. And I apologize to the people in the back who are help supporting this program, and hopefully I'm not giving Stuart a heart attack. I know the drugs. I just can't remember them on camera. But this is looking at it in a different way. And this is saying if we can take these activated B cells and trap them in the lymph nodes where they came from in the first place, can we decrease the overall activity? So another approach to treating MS. Natalizumab, which I should have said was the second, because the S1Ps came third. Natalizumab is a very simple drug, a very effective drug. And what it basically says is that there are activated B cells or T cells that need to cross into the brain. And that's a very complex process. It is very hard to get chemicals into the area, to the spinal fluid around the brain. And what natalizumab does, Tysabri, is it just shuts that down. It shuts down that door. And so that the activated cells the immune cells can't cross over into the brain. The newest generations, the CD20s, these are your Ocrevus, your Briumvis, your Kesimptas. These look at the B cells and they say, B cells, CD20 cells, B cells go through a maturation. So you have an early generation, your progenitor cells that grow and they develop. And as they develop, as they go through school and learn the kindergarten and then they go to high school, and then we can tell that because they put different receptors on their surface. And so by identifying what the receptors on the surface are, you can tell what stage of their maturation they are. And so when you hear a CD20, that's just saying that they are able to identify certain B cells by that receptor, and it blocks that cell from going on. Very effective medications. Each generation has gotten a little bit more effective. And the other thing is, when we talk about MS, we all know that there are differences. If I went around and said, when was your first relapse? How old were you? Did it recover? How much time was it between your relapses? We'd hear 100 different stories. And so there's never going to be one drug for everybody. All right. And so the more options we have, the more opportunities we have to treat people. The real question is, wouldn't it be nice if we could predict this earlier, right? If I could run your tests and come back and say, clearly an S1P, all right? Or you really need a CD20 inhibitor, right? Those are the things that we would like to have access to predict. And I think one of the really cool areas is saying, are there ways that we can measure whether your drug is working for you sooner than so how do we know this now? One is you have a relapse, that's not good. B, you tell me I'm progressing despite being on this drug. And 3, probably the most important and the earliest evidence is your MRI. But now we can do tests that are just coming to the market, a lot of excitement about them, is to say, can we measure some of the breakdown products? We know we can in the spinal fluid. But no one's signing up for their annual lumbar puncture or spinal tap so they can find out if their drug is working. Anybody, if it was curative, maybe. All right? But I don't have anybody saying, it's been 6 months, time for my next LP. So if we can measure those markers in the blood, what is the potential for that? You start on a drug, I'm making numbers up, these are not real numbers, but I like simple numbers so I can do the math. So if you started with a level 100, and you weren't treated before, 100 sounds high to me because I'm making my own numbers up. And you start on your drug and your next level drops to 5. That suggests to me that drug is working really well for you. But what if you start and your level was 100 and you start on drug Z and it goes to 95? Well, maybe that's not the right drug for you. And are there ways we can predict this in an earlier fashion? Maybe you've been on this drug for 5 years and you were at a 5, but now you're starting to creep up. You're a 20, you're a 50. Can we predict in advance that this drug is no longer working for you? I assure you this is an area of enormous research, enormous interest. It was a very hot topic at the ECTRIMS meeting. I did go, Mr. Hunter. I did go to the meeting to talk about where are we with the development of that. Is it ready to come prime time? There are some companies that are bringing it to prime time. We started doing that in our office. A lot of caveats to say this is early. We're not taking any one test and saying this is the answer to whether you need to stay on this drug or switch on your drug. But every information that we can gather that may help us make a more informed decision is very helpful. So the BTKIs. All right, I'll say it once. I hope I say it right since I'm on camera. Butyrin tyrosine kinase inhibitors. I had no idea that there was a serial killer also known as the BTKIs. And so we do a lot of clinical trials. And when I was talking to patients about, there's some new trials that we're doing and the mechanism of action is BTKI, I'd get these really strange looks. And I'm like, I didn't try to say the real name, but I'll try it for you. I assure you I butcher it all the time. But if we have a serial killer for your MS, that's not so bad. But it's not the same thing. This is very interesting because remember I told you we've been targeting, and if you're listening, we've been really targeting MS in the spinal fluid, not in the spinal fluid, in the blood, right? We talked about the peripheral. We talked about trapping immune cells in your lymph nodes. We've talked about blocking immune cells crossing into the brain. We've talked about changing how inflamed you're from more inflammatory to a less inflammatory immune setting. We've talked about identifying certain cells in their maturation and eliminating those. Now we're saying, do we have a class of medications that not only addresses the issues that are happening in the periphery, but do they also address what we know about that's occurring in the brain? And there's a lot of fascinating information about does this, and this ties into the other topic that I'm not sure why Stuart asked me to talk about, but neuroplasticity. I enjoy the topic. Couldn't figure out the flow there, Stuart. But the BTKIs, as in making the immune cells healthier, looking at the cells, when the myelin is breaking down, when the neurons aren't healthy, well, there's these little things called the microglia, and they scavenge and they go out and clean it up. You need some of to be cleaned up. I'm trying to think of an analogy, James. We just cleaned out my son's room. He's been out of the house for about a year. So I think I'm an empty nester, at least this week. And I'm trying to turn his room into my sewing room. And you need a really healthy cleaning up service to make this happen. See where I'm going with this? I can't get my sewing room put together until I clean out all the rest. Junk. I thought that actually worked pretty well. Did that work pretty well? No? All right. Healthy microglia. It sounds better than healthy microglia. And so this is really some of the promise of the new generation medications. One of the hottest announcements I will tell you, when you have a European meeting, particularly if it's in Milan, the day before people travel home, those last afternoon sessions, they tend to not be well attended. I may have missed a few myself in the past, because you get a little itchy and think, well, maybe I should see the city. It was packed to hear some of the emerging information. And one of the things that was conceptual is that I just told you how hard it is to get drugs, anything across that blood-brain barrier, to get into the spinal fluid. And the presentation was about one of the BTKIs showing that not only could it cross, but it crossed at concentrations that would be predicted to be able to have an impact. And so really looking at, when you have a concept, and we all know that there are a number of drugs that are researched that never make it to prime time, right? It might be a safety concern. It may have been that one of the other studies we were doing just got stopped this week, very disappointing, but it didn't show benefit. Right? And that's why we do research, and we appreciate those people who participate in those trials that give us that information. That's my plug for, yes, if you are appropriate for a trial, you should participate in a trial, because how else are we going to get these answers, right? When we talk about these new drugs, there are thousands of people who participated in those trials to give us the information and the options that we have now. And so, the ability to participate in the study is not appropriate for everybody. You may not be an appropriate person for a trial, but consider it, because I really appreciate all that's been done. It's kept me in business for 30 years because I have to keep talking about, I can't do the same presentation because it keeps changing. New information keeps coming. All right, that's my plug for trial participation is important. And it's a wonderful opportunity. And we have 40-something people who are in the BTK trials. There's a number of them now that are contributing to more information about this. So it's a unique, very unique, kind of different conversation to see what we talked about was what the basics were. Now we're evolving into, the basics, and now we understand this mystery. Now we have cells that we can target. We have the ability, because of the science, to be able to make molecules, make medications that can cross the blood-brain barrier, the proof that the concentrations are high enough. So this is such a reason for hope. And I just am amazed every time at how far we've come. And this is even just another slide. You can tell I'm enthusiastic about the BTKIs. But the point, again, being made, the brain penetrant. Standing room only at 3:00 in the afternoon on the last day of a conference. I was amazed I was there, but I was curious. I wanted to hear too. All right, changing topics a little bit. Biosimilars versus generics. They have come to our world, all right? I am the queen of generics, only topped by my husband. During the pandemic, we all had to get generic toilet paper, right? We just had to get what we wanted to get. Turns out I love Charmin. I want only Charmin. I do not want anything but Charmin. I don't want Angel Soft. It was okay before the pandemic. It was okay it was like prize during the pandemic. But now I want my Charmin, all right? And the good news is we can afford Charmin. We actually have 2 different packs of toilet paper in the house. There is the Hughes supply, and then there's a Hunter supply. Oh yeah, because I don't care if he doesn't really need Charmin, don't be paying the money for Charmin. Fair enough? Yeah. And so when my Charmin supply, and I count my rolls. No, I don't count my rolls. I did during the pandemic. I was like, are you using Charmin? We have 2 designated bathrooms. Anybody's married understands that. So a generic is the exact same as the brand name. So if there was a generic Charmin, it would have exact same layers, softness, the same material. I love my Charmin. It just really is one of those things you find out about yourself. I had no idea I was a toilet paper snob until the pandemic. And now it's just as special to me. It's exact same. And in fact, there are great examples of companies that have the same manufacturing plant, the same product, and this one goes over here and gets branded whatever the brand is, and this one goes over here and gets marked generic, but it's exactly the same. And you all know, we've all tried to figure it out, right? Like this, I think this is really, I've never found a match for Charmin. But, like this macaroni and cheese, I think that might be Velveeta, even though it says generic, Velveeta is Velveeta, if you have it. All right, enough of that. But it's the same molecule, all right? I love generics because for a lot of things, it doesn't matter to me, right? Generic beans in a can is the same as brand name beans in a can. I hate to tell you this. I don't see any difference. They got beans. Exact same. And I kind of wish I didn't have to get generic sometimes. I don't have to. I just want to retire sometime. When you're married to a retired person, you go like, I want to do that. I'd say it's a lot of nothing, but he's sitting right there. Just the joy of waking up in the morning and say, what are you going to do? He goes, I don't know. And I'm like, I've got my day planned out and tomorrow, right? But anyway, so unfortunately, these conversations are coming because, a lot of us don't have choices, right? And people are like, I don't want the generic medication. We need to be careful about what's a generic and what's a biosimilar. Now, the reason why there's certain medications that we don't really want to have the generic is because the effectiveness or the amount of drug, for example, for some of the seizure medicines, is it 5% or 10%? Stuart, it doesn't have to be exactly the same, but there is a margin that it can be off. And historically, we've said for seizure disorders, particularly people who have really challenging seizure disorders, that 10%, that 5%, that might matter to them, right? And so we fought for the brand names back when we could win those fights. Biosimilars are a little bit different. A biosimilar may not be the exact same, but it has to have the same effect. Does that make sense? So my degree of, no, I don't think I want to do my toilet paper analogy with this one. You just don't see it ending well, do you? Okay. When you have the original drug, right? And we know that drug showed this degree of relapse reduction. I'm going to get back on topic because the toilet paper thing was going far. Relapse reduction, it had this degree. We have numbers, right? And it shares similar things, but we don't have to go back. It's not exactly the same, but it's similar to the reference biologics. And so the impact, because we're talking about processes, right? We're talking about if I say that this drug affects this cell, then this drug also has to affect this cell in the same way. It's the end point, not necessarily that these two drugs look exactly the same. Does that make sense? Now, do I need to go to toilet paper? Everybody understand with Charmin? Charmin went over just fine. Everybody like, oh yeah, I understand Charmin. I understand hoarding Charmin. So that's a little bit different. In the ideal world, would I ever want to, if brand name A is working for me, would I ever want to have a generic or I know the gut response is no. I want the drug that was working for me, and I don't want to change it. So that's why we vote. See how I threw that in? I got clinical trials in. I got the importance of voting, because a lot of that is not necessarily in our control nowadays. I used to be able to say that get me on the phone with an insurance company and I'll win. I'm a lot more humbled now. All right. I'm a lot more humbled now. And there are a lot of things along the way that are barriers. But I also think that it's fair to have an understanding of what those drugs are, because sometimes I'm like, I really don't have a problem with generic X. I'm okay with the biosimilar. We'll be watching you closely, and if you don't respond or you have a different side effect profile, then we'll have to address it from there. It's not my druthers. I'm sure that's a medical term, right? Druthers? It's not my druthers. And when I go to various meetings, I hear other people talking about their battles. It's a fact of life now. Right? But understanding the differences, I think, is very, very important. Now, in MS, we can have branded generics, we can have branded biosimilars. There's a lot of other layers of complexity to that. But that's a basic kind of understanding. Is that what you wanted, Stuart? You just said, and speak to that. Oh, you try to head off the Q&A. You try. All right. Neuroplasticity. Now this is, I'm going to step on some toes. I'm going to step on my own toes with neuroplasticity. But it's a fascinating topic. And it speaks to an area that I've actually been, I don't know, Stuart, do you know I've gone back to train to be an acupuncturist? The man barely knows me 20 years later. So there are two types of brain plasticity. Neuroplasticity, what is it? We all know that the body is able to adapt, to learn. Children are the best example of that. When they're babies, they don't talk, right? They have to learn to walk. They have to adapt from, crawling to learning to walk. I mean, we understand that, and that happens at such a rate. First they know 3 words, and they know 3,000 words, right? We see that as child, and we used to think at some point that kind of cut off. But the reality is that continues, that all of our brains, women's more than men. I don't think there's any science behind that, but surely that's so, right? I just checked to see if I still have a ride home. Y'all didn't catch that? Women more than men can, okay. But our brains can still adapt and change. And there's really 2 types of brain plasticity. One is the structural, and that is from our experiences. That if we don't adapt to circumstances, if we don't learn new things, right, then it's a very boring position to be in. But it also talks about how do we do new habits. I'm going to go to exercise just so you know, you've been to red alert. And then the functional plasticity. We think a lot about that with people who've had strokes. And we know that, okay, the part of the brain that controls the right arm is dead. I mean, that's what a stroke is, right? That part of the brain has died. But then they start to get more function in that arm. It's not because that part of the brain that was in charge of that came back. It's because other parts of the brain start to take over that role. And that is something that can happen with MS too. And that was another way of talking about the dreaded word, exercise. You see a lot of things, reprogram your brain, when you go on Google, you see a lot of things. But the bottom line is you do have the ability to reprogram your brain. It just may not cost you millions of dollars. And the best example, I love this, it takes 21 days to form a new habit. Everybody's heard that, right? If you want to develop a new habit, you need to commit to it for 21 days. Because after 21 days, your body is used to it. I start exercising and stop exercising, and then I start exercising, and then I stop, right? Because I'm human, right? It's really hard when you start, right? It's hard. In order to fit it in my life, I go at the crack of dawn, and I have a husband who's retired, so, I would just make a lot of noise just for fun. But when I start, because I've paused occasionally, it's really hard to wake up. you're just really mad the whole time you're getting up, right? And then they say if you've been exercising for 10 minutes, if you still want to go home, you can go home. But after 10 minutes, you're kind of into it and it's easier to get started. Well, it takes about a month. Every time you fall off that exercise, anybody in here not fell off the exercise wagon? Bunch of liars. Can I say that on tape, Stuart? Bunch of liars. All right. Bunch of people who do not want to reveal their exercise histories in public. But it's hard to get it started, but once you get started, boy, then it gets easier, right? It just becomes part of your life. You miss it if you don't exercise, right? I hear people say that. I don't know that that's ever happened to me. I haven't been doing it long enough to ever figure that one out. But you do feel better, and you just have that self-motivation. But if you stop, you got to do it all over again. Well, there's a lot of things that we can program in our lives. And that's a great example of like, how do we get a new habit, right? I need to put down my sugar, all right? My coffee is syrup thick right about now. And I have historic, I don't do black coffee, but I've gotten it down to like, a half a teaspoon. It wasn't so bad. Now I'm using tablespoons. And that's just, I like it like that. But I can train my taste buds, right, by cutting it back slowly over time. It'll take me a month, probably a couple of months, because I really like my sugar. I know I need to do it, right? But that's me training. What I'm trying to do is prevent the stroke. That makes me do it for real. But anyway, all right, this is neuroplasticity. And this is really fascinating. And to say, gosh, the brain, I'm always... I've been a neurologist 30-something years now, and I never lose that excitement about talking about the brain because it's amazing, right? All these other fields of medicine, like how many times can you listen to a heart? How many times can you say bone broke? That's really boring. But neurology is just fascinating. And this understanding that the body has this, so how do we harness that? That's the question. How do we harness that? From a medication standpoint, we try to get out of the way, because the body has this process. So maybe the role of the microglia, if it's not healthy, if it's not cleaning up the breakdown products, that might be stopping some of that ability for the brain to heal itself or redirect. So that's one role you might talk about. And then it's the dreaded, physical therapy, occupational therapy, speech therapy, balance therapy, day-to-day exercise, all right? People will say, so I think, how many people have been for vestibular therapy or dizzy therapy, that they had vertigo? Boy, I'm the only one in this entire room. Okay, there's a few people not. Yeah, you've had inner ear problems or vertigo. And what do they teach you to do? They teach you to do an exercise over and over and over. They don't say do it this way this day and do it that way this day. And it's the same exercise over and over and over. But eventually the vertigo gets better, right? It's the same thing with strength. It's the same thing with sensation, all right? There are ways to try to really work with that. And how do we harness that? The best example of that is exercise. Medications, potentially. That's why we always talk about disease-modifying treatments. What can they do to make the system, the brain system, the milieu is the famous, I don't know if I even say that right. Well, it's like the potpourri in which our brain lives, a healthier environment for recovery and neuroplasticity, doing it in a different way. This environment, I probably make more progress with my exercise if I didn't eat quite so much, right? A healthier being recovers much faster. I can tell you, I see this in the office every day. I see people who come in, okay, I'm in the middle of the road. I am not an extremist, all right? I do not think that you should never eat sugar, never pass your lips, never any white, all right? I think you should do it in moderation. Not syrup, maybe down to a light syrup. No, down to my half a teaspoon, where's where I need to be. So what do we do from our ability? So this is your role, right? This is where it gets fun, because a lot of times when we're talking about treating people, we're talking about what we can do with medications. This is where we turn to you like, hey, this is what you got to do. And so what do you do to take care? I know it's that whole healthy and wellness talk again. It just keeps coming up. Might just work. So microglial plasticity, it's kind of one of those side points on the BTKI saying, are the microglia healthier? It's conceptual at this point. I'm not at all saying that the BTKIs are making the microglia clearly healthier, and thus you're going to be able to recover better. But it's certainly theoretical, and seeing healthier cells in the brain, to me, seems to be a great first start. We know that the neurons start to grow, new sprouts. They start to, if that sprout was injured, well, they put out another sprout. It's like a plant. Have you ever pinched off some of the roots and then they come right back? All right, I'm into plants. It's what happens underneath the ground that makes the plant so pretty. And so it's what's happening underneath in the back, this sprouting, this rerouting that allows you to see the benefit of it. This is a great example that we can measure this and prove this. This is looking at functional MRI. I've forgotten what this was, like what the patient was. It's a couple of interesting things. One is if you have weakness on one side, but you think about moving that side, the same part of the brain lights up as though you were moving that side. It's just remarkable the underpinnings that are setting us up for success from neuroplasticity standpoint. And then structural, what you're seeing on the right with the blue and the green and the red, but what they're showing here, and don't ask me to point to the spot, is where there are new connections, right? That we can actually measure where the routes, the tracks in the brain are being done. So it's a proof that neuroplasticity is a thing. I'll throw in my new, I don't know, it's so interesting. I don't know, some of you have been to programs before. When I came in, Jill said, how's the leg? I broke my foot like 2 years ago and had a lot of functional problems. And I use acupuncture as one of the tools. I'm always really clear. Yes, I take meds for it. Yes, I have a spinal cord stimulator, but acupuncture is one of the tools that I use for recovery. So I don't want anybody calling me and say, I'm going to give up my disease-modifying treatment. I just want acupuncture. I just head that off from the beginning, Stuart. Yeah, I had to, all right? But we're all asking for tools to say what potentially can. And there is some interest. There's a lot of interest. Actually, I just came back from both in the Chinese acupuncture and the Japanese acupuncture, looking at more of a rehabilitative acupuncture. And so in China, and there are a lot of centers here, a lot of the big name Ivy League hospital systems are starting to develop integrative care programs where acupuncture is one of the tools. And so in China, if you, biggest use of acupuncture in the United States is pain. It's very effective for pain. The biggest use in China is rehab. All right. So if you have a stroke, you're met in the ER with a acupuncturist. When you go to the floor and you're going through rehab, an acupuncturist is working with you. And so it's very interesting to think about how other countries are using this. Acupuncture has been around 2,000 years. The challenges from the Western standpoint, we're always trying to explain how it works. But showing this brain activity and showing that this is ear acupuncture, and you see on the left with the little circle, and then after acupuncture treatments, you see that activation. So there may be other ways. And I know this 80% of people in the room are using some alternative or complementary treatment for their MS. They're either doing it now or they're doing it in the past. So don't be looking all innocent. Statistics have not changed on that. Access to MS care and telehealth. I don't know why he threw this in here. MS is a very complex disease. How do we build those systems around people? There are some centers that are able to have all that in one place. There are other places that try to have like referral lines. I will never have a social worker, unless somebody gives me $10 million. It used to be $1 million, but now $10 million maybe. But a social worker, a neuropsychologist, all these different resources that you living with MS at some time in your journey is probably going to need, right? Telehealth. During the pandemic, 1 in 4 Medicare patients had a visit within 6 months by telehealth. 1 in 4. Telehealth's been around a long time. Long time. I was junior faculty. It was a junior faculty's job to go do telehealth visits way back. But it was big and bulky. It was huge equipment. Now it's your phone, right? How many of you have done a telehealth visit? And at first, people were like not so sure if they wanted to do a telehealth. And you're right. There's some things I got to touch. If you're talking to me about your spasticity, it's really hard for me to assess that from a telehealth visit. If I'm following up on, hey, I started new medicine, I want to make sure you're tolerating it okay. Nothing on you I really need to touch. It's you're telling me your patient experience, right? So how can we use those two resources? I'll tell you a secret. Telehealth ain't going nowhere. Because now people will call and say, yeah, no, I'm doing great. I just need some refills. Can we just do that by telehealth? Right? I will admit to pulling over on the side of the road because I was caught in traffic and calling my doctor and said, could we just do this by telehealth? Because you ain't going to touch me. No, but it was, it was just a follow-up visit. And I was like, why am I fighting all this traffic to get across there, to just answer a few questions? So the role of telehealth, probably even more important though, is how good is it? Because that was a big question. Just because we was doing it didn't mean it was working well. And there are numerous studies that have shown everything from telehealth benefits and efficacy in people living with MS, living with other neurologic diseases, showing in primary care, right? We've been doing telehealth for stroke alerts for years because we have a very standardized exam. The effectiveness for doing telehealth for stroke has been shown, and it is standard of care to have access to either that or a neurologist in the ER. And because there is an enormous shortage of neurologists, I brought it here, but he told me to hurry up, so I'm not going to read it to you. I wasn't going to read it to you anyway. So I wrote my talk, and then, I was cleaning off the journals. I try to do that once a month just because they pile up and look for what's interesting. You may not have found it as interesting as I did, but the shortage of neurologists, it's a huge problem, right? And shortage of neurologists who are interested in MS. And when I say interested, I mean interested and focused on keeping, not I see a few MS patients a year and I'm interested in those patients, but really do a larger volume. Because MS is not easy. I don't know if y'all figured that out. I figured it out. MS is not easy, all right? And so you need a lot of experience. You need to stay on top of it. You need to go to conferences. So when you're evaluating your own care, I think those are fair questions, all right? Don't ask me how to manage your toe fungus. I don't know. I ain't read an article on it lately. I watch TV just like you do. It's like that woman skipping with the toenails showing. That's the drug you should take, right? You need a little bit further depth than that. The other thing that was interesting, in order to see a specialty neurologist, to see a neurologist in rural areas, almost 20% of people drive over 80 miles to go see a neurologist. And I thought that was horrible until I thought about my patients driving from Columbia. I said, ooh. I was like, I can't make that drive. James, you're going to have to drive me. That's a long way. I went to work today. Then I tried to do it. So I'm very appreciative of that. And I hope, and I encourage people to see a neurologist, and I know that's on Stuart's radar screen of things he finds very important, is that I do think there's a benefit. And then one of the things with being here is hopefully you hear how this field has evolved and how much more information and how much more opportunity is and focus around not only treating the disease process itself, but also making sure we're taking care of the rest of you. I always said for years, nobody's ever called me and said, listen, I just did my disease modifying treatment and I just wanted to say thank you. Control somebody's bladder, all right? Help them sleep better, manage their pain, manage their spasticity, help them get to the occupational therapist or the physical therapist, because, I don't do any work with that. I just take the credit. I sent you to physical therapy, you're walking better. Well, thank you. But sending you to, so that's where all of us see the benefit in our lives, okay? I never called my orthopedic surgeon and said, I appreciate you doing an x-ray again today. Because I just, it was great. But I did appreciate the physical therapists, right, who worked with me. And so those are the things about quality of life I think is very important. And when I hear like someone say like, oh no, I haven't been to physical therapists in 10 years, 5 years, I've never been to physical therapy. All right, you're missing out on a very large portion of what should be done to help manage your MS. Future of telemedicine, it's not going anywhere. All right. In fact, the models around that, whether it's chronic health management, so it's throughout your care, they're, actually coming through the San Francisco airport, because I was traveling last night. There's all these monitors to say, see a healthcare provider right now. I don't know what's going on in the airport, but I'm sure they're advertising some agency. But just this ability to say like, hey, I'm in the airport. I need to talk to you about my ex. You could see somebody right now. How flexible is that? How many more times might you do that visit if you have versus having to schedule something and find time on your calendar to drive? Notice I said there's some things I can't do through telehealth. Prescription compliance. All the pharmaceutical companies about now have somebody calls and checks on you and make sure you're tolerating it. Thank goodness it's them, because I don't have enough staff to do that. But that might be another role for telemedicine. So the future of telehealth. And then I just threw that in there. I might have to take it down really fast. This is my last slide. And to say that we're all trying to look at ways to manage people with MS. And it takes a lot of different services. And so I am a very proud owner of a building. Actually, I don't own it. The bank owns it. I'm really broke, and I just owe the bank a lot of money. But what we've tried to do is what many people are trying to do, is to bring different resources under one roof so that we can really enhance the care of people living with MS. I look forward to potentially talking. Have Stuart come back and talk to you about acupuncture. I think it's fascinating. All right, that's my thank you. Then I get nervous. You see, I don't even look at y'all. I'm like, what's Stuart got for me? All right, thank you.
Good round of applause. That's nice.
What symptoms do you recommend acupuncture for?
Oh, very interesting. So I like to. So there's a lot of things that can be managed, and a lot of conversations about the gaps, right? So is this a medicine? One of the concerns with people living with MS is polypharmacy. All right. And so are there alternative ways to treat symptoms? So I mentioned pain is a big one, but fatigue, spasticity, headaches. There's a lot of uses. My personal focus has been around kind of the neurologic. And we've been doing some scalp acupuncture for functional rehab. It turns out as a side effect, you grow more hair. Who knew? I sent a picture. Well, my husband's not. I tried to help. You got that, didn't you? Yeah, I too. But so there's, it's acupuncture in many countries is a health system, right? So it can be used for many different things. But I think really where my interest is that there are just times when you've not responded to a lot of medications, or the side effect profile may not be. Or it's a nice thing to try instead. So I think we're really specific about it. I think acupuncturists would tell you just about everything can be treated. I will confess, the joy of becoming an acupuncturist is that, those needles can travel home. And I think everything from I ate something wrong, my stomach, 2:00 in the morning, I woke up, my stomach was just churning. And I could take my Zofran, but it gives me a little bit of a hangover effect, and I knew I had a busy day, so I got those needles out, and I think my husband rolled over and saw I had some needles in my belly, and he just went, I got nothing. But my stomach was much better, and there's no hangover effect, And so, so there's a wide range of things. No, you're not going to get needles to take home. It's just a benefit. Yes, sir. Lauren? Man I've never met before.
Do acupuncture help, like with limited sensation?
So it's like anything else in the world, right? Is that some people respond really well, some people may not see benefit. Are there approaches for treating numbness? Yes. All right. That's what I'll say for that. Mm-hmm.
How do you feel about doing herbal remedies?
It depends on the herbal remedies. So part of training to be an acupuncturist, for example, is that you have the option of training for herbals. And I'm not smart enough. I'm really just not smart enough. But so I think some people will say just because it's natural. Well, you can naturally die, all right? And natural substances can also have side effects. And so we've emphasized for years, it's very important for us to know not only what you're taking that's been prescribed, but you're taking what's not prescribed, that you get over the counter or from your barbershop or from those kind of things. There are some great resources. The NIH has a wonderful research for complementary medications or herbs, so you can look them up. I too sometimes run around the corner and look them up. The Rocky Mountain MS Center has had a great website over the years. I don't know if it's still up, that has looked at. And so it gives us an opportunity to look at what are the potential. I think not that long ago, there was a big, in the migraine field, there was a lot of interest in butterbur. Turns out butterbur can also affect your liver. All right, so you need to be careful about that and know that, and you need to have your liver tested regularly, just as if you were on a prescription drug. So those are the things where it's really important to. There's a reason why I'm not a pharmacist, right? Because there's so much they need to know. I've just kind of, I know enough to be dangerous, but I really respect that and say that making sure you're aware of working with somebody who really has knowledge base, and then making sure your provider knows what you're taking.
All right. First one online wants to know. First one wants to know if Dr. Hughes is taking any new patients.
Why, yes, I am.
Okay,
I
there's
just
your
put
answer.
that last slide
Vicky.
up. The phone.
Okay, great. All right, next we have a person that wants to know more about microglia. So they said that they don't really understand what you were just talking about, so there must be more.
Okay, so there are different cells within the brain. The neurons, which we think about the actual nerve cells, where a neuron talks to the next cell, talks to the next cell. But you also have cells that are, I really think of the microglia as the cleanup cells. All right. And then that's what their role is that, there's junk in your brain too. Breakdown products that the brain naturally makes. We know that the brain cells turn over at a certain rate. There's something called apoptosis, where there's a normal aging of brain cells. And so they age and they have a lifespan, and then the microglia come in and clean that up. If you look at, for example, around the periphery of a stroke, the microglia are what coming in to clean up the cells that have died. And so they're kind of the cleanup cells. They're not a structural cell. They're not the cell that's passing the information through, but they're very important in kind of keeping a good household for the brain.
Dr. Hughes, let's assume you have a new patient.
Mm-hmm.
You're just diagnosing this patient. Would you use the Octave test?
Octave. So we are using the Octave labs, and that's the labs that I was telling you about. There's like 18 biomarkers that are measured. I can only explain about 3 or 4 of them, just in all disclosure. One of the biomarkers is something called the neurofilament levels. And so the neurofilaments are the structural components of the neurons. And so I told you the cells have a normal break turnover rate, right? So I have a certain neurofilament level, you have a certain neurofilament level. But if you have any disease that affects or accelerates the turnover of neurons, those levels go up. MS is obviously a great example of that. And in many very preclinical studies, like in animals and those kind of things, and from studies that have collected spinal fluid, it's been shown that if you come in and you have, just because we say it's a new diagnosis of MS, well, you've had it, right? We used to estimate it took about 7 years from the time of onset of MS and when you finally got diagnosed. Hopefully today it's much shorter than that, but that process has started years before you actually present. And so the expectation would be that your neurofilament levels will be high. You're untreated, all right? And that's where every single pharmaceutical company is trying to figure out the neurofilament level test for their drug, right? So that you start on your drug and you go like, wow, look, your 100 went to 5. Because then you have that feedback on this drug is working. In diabetes, we have the hemoglobin A1C, right? And so if I had a newly diagnosed diabetic, I'd check their hemoglobin A1C, and now we know, okay, you're a 15. That's really not good. We need to be down around a 5 point something 6. All right. And so but you're diabetic, you were doing great. You were down to half a teaspoon of sugar in your coffee. I'm not a diabetic, but if I don't put that sugar down, I'm headed that way. But now you're starting to creep up. Now your hemoglobin is a 9, right? Well, you're not doing as well as you used to. Sometimes it's slipped and you're eating too much cake, or your regimen that you were taking for your diabetes is not working as well for you. So with the caveats of this is early generation testing, that it's not, I can speak extensively to the hemoglobin A1C, which has been very well validated. All those disclaimers, I think that information is helpful, but it's not the only piece of information I'm making my decisions on. All right. And as it is translate from the research world to the clinical world, I think we're going to be able to be more definitive about what that means.
So now that you said all of that, what about neurofilament light change?
Yeah. I mean, these are all things that we are trying, that's starting to translate. I mean, I think even I mentioned we started assessment clinic. If you're in an MS trial, you get an MRI, but you get a really detailed neuro exam. You get cognitive testing. You get your 9-hole peg testing, the dexterity, the fancy Cracker Barrel tic-tac-toe. We're doing all that to assess how you're doing. How do you translate that to the real world? It's next to impossible to get an evaluation by a neuropsychologist, and it's rarely covered by insurance. It's $1,000-something. So can we use computerized cognitive testing? And we need that information because no MS affects the cognition. How do I pick up on that? If you don't think I'm funny, something's wrong with your cognition. That's been my oldest test. But how can we look at, and we're starting to use those tools in our office to say, okay, it's maybe not as good as a neuropsychologist, but it's getting mighty close, and I don't have access to that neuropsychologist.
Thank you. Next question. Going back to the microglia, a person asks, so is it the microglia that turns T2 lesions into black holes, T1?
So the answer is, I don't know. I don't think so, because a black hole is a reflection of the loss of the wires, right? This neurodegeneration. I don't know if it's the microglia cleaning that up that makes it show on an MRI as a black hole. So I don't know.
Next person is asking, how long can Ocrevus be taken if it's not working well? How do you know if it's not working well?
That is not a quick question. So
it's
if a drug,
question.
if a drug is not working for you, then no, you shouldn't stay on it. But the other side is, how long does it take for Ocrevus to really show a benefit? So going back to the clinical trials, the benefit was shown after 6 months. Remember, these are 2-year trials. And so if you take a dose of Ocrevus, I think it's, I can't even understand me. I'm going to slow myself right back to where I usually am. Ocrevus, if you start on Ocrevus today and you call me next week and say it's not working, I know. And if you call me in 5 months, I go, I know. It probably takes 6 months to a year to really start having a full effect. And so when we talk about rebaselining, right? So when should we repeat an MRI? So not to test whether the drug is working yet. It should be starting, but to say this is your new baseline on Ocrevus, right? So you have to know, how long does it take for the drug to have its full effect before you can say that it is or is not working. And then life is hard. Sometimes you may have diabetes and MS, and you're like, I'm not doing well, right? Is it the diabetes or is it the Ocrevus? So we have to look at all that information before we can say whether or not you're on. Now, we have to be careful, though, because all of these drugs are affecting your immune system from different directions. And we recognize that an immune system is there for a reason. Your immune system is what's looking for abnormal cells. So it's looking for cancer cells. And if we affect your immune system from too many different directions, we may be putting you at a higher risk. Theoretical. But these are the reasons why we don't go like, it's Tuesday. Let's switch you from Ocrevus to drug Z. Notice in the back, I did not name a second drug. I'm good at this.
Thank you. Next question is, what is the most recent update on demyelination?
I don't know that there's a most. So I guess the bigger question, interest, is remyelination, right? We've been documenting demyelination forever. The question is, what can we do to remyelinate? I think a lot of that, when we talk about potentially, all this is theoretical at this point, is to say, if we have healthier microglia, then does that make things? There's my favorite cell is the oligodendrocyte. Good thing I didn't have a girl, because that'd been a good name, oligodendrocyte. But that is the cell that makes myelin, and we thought for a long time. So like when children are born, babies they myelinate. They don't remyelinate. They myelinate for the next 5 to 6 years, and then it sort of pauses because they don't have grown brains, but they have myelinated brains. So we thought those cells kind of stopped working. Turns out they're still there and they have the potential to work, but how do we make those oligodendrocytes, which are already in the brain, able to perform in a healthier way, maybe reactivate them? So there have been trials in the past that have tried to look at ways to increase the activity of the oligodendrocytes so that you remyelinate more. But you got to be careful, because just because you turn on myelination, you need to be able to modulate that and make sure it doesn't turn on too much, because if you have too much myelin, well, there are tumors that are made of too much myelin. So it's a very tricky.
Thank you for that. Next one, are BTK1 trials still enrolling for folks older than 60 years old?
I can't speak to all of the trials, because there are, see how I'm hedging. What's interesting is that there are 6 or 7 different BTKI inhibitors that are being studied right now. Even as the first generation drugs are being studied, there are newer generations, adaptions to the first class. Unfortunately, a vast majority of studies use 60 as a cutoff. There's some that use 55, which has really hurt my feelings lately. I'm 25, but I just feel bad for the 55s. Although I did order off of IHOP's 55 plus mid. I got to save my money from a Charmin.
Exactly. So I have another question for you concerning those over 60 years old. What do you tell an MS patient who is very stable? I'm not talking about one of your one of your patients, all right?
All right, not my patient.
I'm talking about a person that has a problem with that their neurologist is asking them or telling them that they're 65 years old, that they've been stable for 10 years, and it's time to get off their medication.
Well, last time I checked, and it's getting younger by the minute, 65 ain't old. All right. And so as far as I'm concerned, I'm not really going, well, I'm 65, I'll just stop now. So there's a couple of things that and this is a hot topic about is there an age where we should stop medications? We use terms like the healthy old and the old. All right. We've all seen 55-year-olds that look great and dynamic, and we've seen 55-year-olds, nobody in this room, for the record, but 55-year-olds that just look like they should be 90, right? So that's one thing. The second is, I love it when people tell me that they don't need to be on drugs anymore because they're doing so well. I'm like, why were you taking the medication in the first place, right? The medication is supposed to work well. And is it that you're doing so well because the medication is working in your system? Or is it you'd have done this well without it? Well, we know from natural history studies, don't try that. Don't try just coming off your meds and seeing how you do. It doesn't go well. MS changes over time. There's no question about that. Our immune cells get older. So is the risk of being on these medications changing as you age? Is it a healthy person? Is it an unhealthy person? Are you starting to have a lot of recurrent infections? So there's so much that goes into that. But I will say this, here's my own perspective. I personally do not take people off based on a specific number. I rarely take, okay. And then I had the 90-year-old that came in and I was like, I don't think you need to take it anymore. And she fired me because she was very upset. But I was like, you're 90. So that's, at 90, she's like, well, I was like, okay. But if you have a relapse at 65 or 70, and yes, it can happen, your recovery is not as good as it would be when you were 20, right? And so that's the thing that I'm probably most worried about is it's a big gamble. And until we have tests, like perhaps theoretically, maybe, you hear a lot of disclaimers here, that maybe we'd use the Octave labs and we'd use the biomarkers to say your labs are 5. We're going to take you off and let's see that, and we'll just keep following you and make sure they stay a 5 and they start to creep up. I'm just not that smart to figure out who's not going to progress or not have a relapse and who is. So unless there's a medical reason why I need to say maybe we come off for a while, no.
I was going to give you one more question, but I see there are 2 people up over here.
Thought you were going to give me 50.
First, thank you for asking the question I was going to ask, but I do have another. What would you say to the person that does not want to they are diagnosed with MS and they don't want to take a MS disease-modifying therapy because of all the side effects of all the different drugs?
So I have a very blunt answer to that. Have you seen MS off drugs? So we have years of data of what MS looks like untreated. We have years of data of what MS looks like on the first generation, the second generation. And I'm more afraid of MS than I am of the side effects. Now, I've also never said to somebody, I don't care how bad you feel, but you better stay on that drug, okay? People who were on the injectables, are quite appropriate in that, well, we did feel like, we were like, do that shot. I don't care how bad you feel. We're going to pre-medicate those. Because what we were treating, I think, was scarier than what the side effect profile was. Today's generations of medications, side effect profiles are so much nicer. The risks are so much nicer. Yes, we have to monitor them, but I'm more afraid of MS. I met a lot of MS. And my perspective is like, oh no. Yep. I get kind of blunt about it. One germ mic. Did you forget the rule?
Okay, I have more of a comment, not really a question. I'm going more off of what you were saying, and as far as people getting off the medication, wanting to get off the medication later on, is that, of course, you wouldn't go cold turkey on doing that. That's why there are exercise physiologists that are out there to help you get off of medication.
Okay, I'm just going to say I got the other mic, and I would say your role, is that what you do? And so what I hope that so I will disagree with exercise physiologists can help you get off your MS drugs. An exercise physiologist may help me get off my diabetes medicine. They may bring my hypertension down, okay? But I am not comfortable saying that an exercise physiologist can bring you off your disease-modifying treatment. It may enhance the bit. I'm just like cutting you off because I don't want anybody hearing that they see, I'm sorry.
No, they go off a list of different things. So then you don't just walk in the office and they say, oh, I'm going to take you off this medication. There's a list that you have to go through, something that's called a PAR-Q. You have to go through a certain test in order for you to be qualified.
I've been doing MS
you have
for
to get
30 years.
You have to get approval. You got to get a clearance, all that stuff through your doctor before
so
they can approve
here's how I
you.
treat. I have a sister who has MS. If I wouldn't recommend it for her, I wouldn't recommend it for anybody else. All right? People, I know that, so I wish I could tell you, every patient came in my office, agreed with me. I wish I could tell you that, all right? But that's not what happens. People come in and I have to respect their opinions. And here's what I tell them, is that you and I'll tell you I'll give you the best advice I've got. And I'll try to back it up with science, all right? I'll give you that. If you and I agree to disagree, every visit you come in, I'm going to go back to that, okay? But if you tell me something like an exercise physiologist can help you come off your MS drugs, then I will throw myself down on the ground and throw a tantrum. Because I think you're doing something dangerous. And I do not have to be involved in the care of someone who's doing something dangerous. So you will need to find another neurologist to see. Because the bottom line is there's a whole lot of people who need to see a neurologist who is very involved with their care. And that's where I'm going to go spend my time. I'll see you when you come back. I will take you back. Because you know what? I know you're coming back.
With that being said,
Other than that, I have no
anybody
emotions
have a question
about that.
out here? Anybody else have a question? Then you do have a question.
Oh, now people have
Oh my
questions.
gosh, of
I
course.
done got my heart rate all up. I was like, nope, not in my office. That's how I feel about
This
it.
is what happens with
Can
age.
you tell how I feel?
This is what happens with age. People forget.
Ouch.
You know, you've been covering a lot of things, and our son has been diagnosed probably about 4 or 5 years. How do you respond to still emphasize less stress, watch your vitamin D, watch what you eat, also exercise, things that are within your control, and how important that is?
So I have a son that's 24, and I'm giving him that same advice. And I was given that advice when I was 24. But it didn't mean as much till I started age, all right? And so that's advice every single one of us are working to follow, right? But the reality is, so there's two things. I said I have a sister who has MS, and one of the most poignant memories I have, she may not remember, but I do, is we were doing this presentation, and I was a doctor, and she's a doctor patient. So she was in her patient experience, right? And I was being the doctor to explain, like, oh, this is what alloclonal is, right? That kind of presentation. So she said, I have been diagnosed 10 years, and I'm just now accepting it. And I'm glad we weren't on camera, because I was told the way my head whipped around and the look I shot her is that we've been doing this for 10 years, and you just now accepting it? But the reality is that MS is a journey, and the acceptance and the grieving process is a long one, right? And people have to accept it in different ways. So if you think about the stages of grieving, the first one's denial. Second one's anger. Third one's bargaining. And then people sometimes never get past that. They go back to denial. They go back to anger, right? Eventually, maybe people get to acceptance, but not everybody goes through all those stages, right? And so he may be at the denial, and you have to try to meet him where he is, right? The other thing is, and this is what I would tell people who come in my office with crazy thoughts like stop their drugs, is I will be sad because I know that that's not the best advice, but I also know I did everything I could to encourage it, right? So if you say to your son, well, you need to exercise, and he goes, man, I can't afford a gym, and you're like, well, I ain't paying for that. Or you don't get bands. A lot of us can't afford gyms, right? And you don't offer to help those resources, and that's one thing, right? But if you've at least opened that conversation, sometimes people have to hear it over and over and over. I know my husband's over there like, I've been telling her and telling her and telling her, right? But sometimes you have to hear it multiple times, and you just have to hear it in a different phase. And so that's the hard thing in life, right?
Thank you. This way, one last question, all right?
Woman I've never met before.
When you're talking about the treatments, where does Mavenclad fall in?
So Mavenclad's an interesting conversation. The way we think Mavenclad works is it sort of resets the system. It targets your lymphocytes. It decreases them and allows them to grow up in a healthier manner. And so it is a way of changing the activated immune cells. So when you've adapted, your body now recognizes certain things as being abnormal, right? It has memory for that. And so what you're doing is targeting a subset of those cells and allowing a hopefully healthier immune system to grow back. So it doesn't keep recognizing, you're right, that wasn't on my slide. Sorry about that. Recognizing, so a healthier immune system comes back. And there's proof that the cells that you have, the subtypes of your cells, the markers of the cells pre-Mavenclad and after Mavenclad are different.
Okay, I was afraid that I was going to get one of those things where it's going to be, oh, it's gone. But she mentioned Mavenclad. I'm not sure if I'm pronouncing that correctly.
That's correct.
And you just mentioned that can it be used in additional to Ocrevus?
No. So remember I mentioned that we got to be careful. All right. And that actually, remember I mentioned that presentation that was so wrong however many years ago, my rocket slide? And so I said, well, okay, we have this drug. And then if that drug doesn't work, then we'll add this drug and then boost the effectiveness. And it just built. It was a very nice slide. All right. And what we recognize is a little something called PML came around. And we were like, whoa, I was surprised to find out I was a real doctor, right? That I had to be worried about real things because we were suddenly finding out that we were so much more effective than we thought we were. And then we really had to talk about the risk and the benefits. And so we do not combine medications and there's a reason why we don't, right? Because you still need to be able to fight off infections, right? You still need to be over, pandemics come. We didn't anticipate that. We had a lot of conversations about the safety of our medications. And so those are all conversations we have to be really aware of. So no, we don't. There are rare occasions, because I'm sure there are rare occasions where patients are on unique treatment protocols. But there usually is a very unique situation there in this day and age. Okay? But the right answer is no.
Thank you for coming here today. I know it was a long ride. I appreciate
It's
all
a
of it.
long ride. And then serve me dinner. Does anybody see an extra plate set aside with Hughes' name on it?
There is actually. And your husband didn't want to take one before either.
You should have fed my husband. He's driving.
I tried. He didn't want to take it.
Driving.
I asked him if he wanted it. He didn't want to take it. Thank you very much for
Thank
coming
you,
on
Steve.
down from Greenville. Gotcha. And listen, these people wanted to hear you. I mean, Coy was after me to get a program going here in Columbia, and you could only have Dr. Hughes come down. All right? So that's why we're doing that. And everybody online, this is why you heard one of the best. All
Thank
right?
you.
This is why you heard one of the
Says that all the
best.
time because I've watched them as other presentations. So take that with a grain of salt.
Thank you again for coming tonight, and drive home safely. Bye-bye.